on growing to adult phases. If not taken care of, most of these pseudo class 3s do turn into true skeletal defects later on. So let's talk about the pseudo or functional class 3s. Now, why is it called a pseudo? Pseudo is a fake, and a functional is something to do with a function caused by a function, habitual. So basically, a pseudo class 3 patient is basically identified as an anterior crossbite with associated functional anterior shift of the mandible. Everybody will know this. I'm just going through a little bit of literature before we go on to the clinical management. And I have something different today. I'm not going to be going into the routine face mask and the 2x4, which all of you already know. It's going to be a little different as to how we treat the TMJ as well, and some relations and correlationships between the temporomandibular joint as well as these class 3s. So although the mandible begins to close in a class 1 skeletal pattern in pseudo class 3s, it's guided or shift it forward to a class 3 on first contact between the incisors. So most probably there is some prematurity in the anterior region, usually. And sometimes, even before it touches, it guides and glides to a guide in the mandible. And the patient would not be able to occlude his posterior teeth unless and until he guides the mandible forward. So this is one of the very important distinguishing factors when it comes to diagnosing a pseudo or a true class 3. If the mandible is manipulated into its terminal hinge axis, you can definitely see that the teeth are able to go to an end-on relationship, indicating that it's more of a dental and not a skeletal issue. So let's just move on quickly onto the characteristics of a pseudo class 3. You will of course find an underjet, retroclined upper incisors, which is not very common in a true class 3. In a true class 3, the compensatory mechanism is going to be the opposite. It's more of flared upper incisors and retroclined lower incisors. But in this, most probably, I'm not saying in all cases, most probably you would find retroclined upper incisors, labially placed lower incisors or flared lower incisors, and deficiency in the maxillary arch perimeter, which is very, very important characteristic. You will have narrow arches. Mid-face deficiency may be prominent, probably because of the incisors, upper incisors, and the appearance of the mandible prognathism because of his forward bite. And finally, the vertical development is absolutely normal. Now, this and one important factor that I have seen in my clinical cases is most of the time, of course, because of the anterior guidance, you have the midline. Now, how I diagnose this is something that I would like to share with you. Is when the patient, usually you ask the patient to sit in front of you, and then you have to ask him to open his mouth. Maximum mouth opening, you will find that the mandible guides itself towards the facial midline, and his midlines are coincident with the facial midline. But if the midline is not coincident even on maximum mouth opening, that is a very good indication that the pseudo class 3 has probably traversed into a full-blown skeletal class 3 with one side of the mandible which is overgrown the other, and that's why it's not able to shift back. Now, unilateral posterior crossbite definitely is one of the most important diagnostic features, especially when it comes to a pseudo class 3, because of the functional shift or because of the glide in the mandible towards one or the other side. So basically, over the years, class 3 treatment, especially pseudo, have been focused on protraction or proclination or flaring of the upper incisors, and just to get an ideal positive overjet, which would correct the premature contacts and which would resolve the pseudo class 3. So these have long-term benefits. They've shown to have a lot of long-term benefits over the years. Now let's just go on to why do such people or some subjects usually have this pseudo class 3. There are many theories, and one of the most conflicting theory is that Is a pseudo class 3 dependent on the occlusion? Is the occlusion a relative factor which influences the pseudo class 3 or the functional shift? Or is it something else altogether? So the most frequent cause of a unilateral posterior crossbite is a reduction of the maxillary dental arch. Now, this may either be reduced because of a finger or a dummy sucking, or some different kind of swallowing habits and obstruction of the upper airway due to adenoid tissue or nasal allergy, which have actually constricted the maxillary arch. So the concept of how the pseudo class 3 develops is such that because initially there is a discrepancy between the maxillary and the mandibular arch widths. As I mentioned, the maxillary is smaller than the mandibular because of some certain etiologies that have been discussed in the previous slide. And now this, over a period of time, generates a neuromuscular guidance of the mandible, which is generated by the central nervous system. And then the neuromuscular guidance is what causes a force guidance, causing a lateral deviation of the mandible into a posterior crossbite. Now that sometimes may just be, which may not cause an anterior crossbite, but most of the times it causes an anterior crossbite and glides the mandible forward to get ideal intercuspation of the posterior teeth. So over the period, and most of us also do, and by the way, let me just also reiterate the fact that these cases of pseudo class 3s are best treated in their early years and not as adults, because of the fact that a pseudo class 3, if left untreated, may develop into a full-blown skeletal class 3 later. And there are studies which also say that even though the skeletal pattern is class 1, with a pseudo class 3, if left untreated, may become a very severe class 3 later. And you know, the reason behind that is that a pseudo class 3 as a function is something like, you think of it reverse. Imagine that the lowers are in front of yours, and that does not let the uppers go forward, that does not let the maxilla grow. And that is one of the very common theories which is attributed towards a full-blown class 3 resulting out of a pseudo class 3. So now the key to the early improvement of a pseudo class 3 is the labial advancement of the maxillary incisors out of crossbite into a normal overjet. So many things have been used, like a 2x4 appliance. You can just bond 4 teeth in the front, 2 molars at the back, and then you can use elastics, something like a class 3 elastics with an open coil spring there, you know. I don't know if YouTube's for me that
Adith, there is a problem with your network. I guess if you can just stop your video.
Yes, sir.
Yeah, if you can stop your video.
Stop video. Okay.
Yeah.
So is it getting better now?
Because yeah, now it is better. Because there was a lag in voice.
It's always a problem here, so I don't understand why.
No problem.
Okay, now is it clear? So please stop me if it is not clear.
Yeah,
okay?
Sure, better.
Okay, right. So do you want me to repeat?
Yeah, please repeat it little bit.
The previous slide, I guess.
No, this one only.
Okay. So what I'm trying to say basically over here is that the key to the improvement of a pseudo class 3 is basically the labial advancement of the maxillary incisors. What I was trying to basically say is that there is the pseudo class 3 acts like a functional appliance, or like a reverse twin block for a class 3. In the sense, what happens is, this is the bite. Now, the bite, imagine a bite in which the lower incisors are ahead of the upper incisors, and it does not let the upper incisors go forward. During a growing phase, it acts as an inhibitor to the maxillary advancement itself. And that is exactly why a pseudo class 3, if left untreated in the very beginning, would develop into a full-blown class 3 later on. Now, the key to the improvement of a pseudo class 3 is, as I mentioned, labial advancement of the maxillary incisors. There are many ways of doing it. One could place a 2x4 appliance, and you have 4 brackets in the front, 2 buccal tubes at the back, and you can put in a open coil spring over there in order to just procline the incisors a little forward, because as I've mentioned, the upper incisors are usually retroclined in a pseudo class 3. So they can take a little bit of proclination as well without harming the inclination of, or the U1SN values of upper incisors. Number 2 is face masks. Of course, everybody know the use of a reverse pull headgear in order to correct such bites. It also, reverse pull headgears have been known to have a very good effect on the profile of the patients. And there was this very recent study that I think has been posted by Dr. Padraig Fleming in the group, the World Orthodontic Study Group as well, which says that those subjects which have been treated with a face mask in their early years do not require, and the numbers of the patients who would require subsequent surgeries are far lesser. Also, advancing loops. Now, I don't know how many of you use advancing loops. I use a lot of advancing loops in my practice. How I usually fabricate them is using an 016 stainless steel, and I place a stop loop, a little bit of a stop loop or a cherry loop or an omega loop, but I make and I fabricate the omega loop starting from the buccal tube. So it's not before the buccal tube, it's on the buccal tube. So what happens is when you try to place the wire inside, the anterior segment is always ahead of the incisors. And then you just push them back inside, and then you ligate them onto the incisors, and that's going to give you a forward thrust on it. All of this, again, depends case-wise. If your incisors are not flared in the very beginning, you could have used all these methods. You can also use compressed superelastic wires, as you can see in this picture over here. That's an eye tie, and there is a stop created over here, and you can see the bend. The bend is going to push these teeth forward. You might also see some amount of distalization, but it's in a growing patient, it's hardly ever the distalization. It's more of the proclination that takes place. Compressed coil springs, like in this case, also can be used. It's starting using an open coil spring over there in order to push your upper teeth forward. So now a little the concept of structural position of the mandible was basically characteristics that provide optimal functional condition of mastication and is basically the position in which all muscles and the temporomandibular joint is optimal harmony. Intercuspal is just the position in which the mandible maxillary teeth occlude properly. The structural position need not coincide with the intercuspal position at all times. And that small discrepancy between the ICP and the SP is what actually causes a physical strain on the muscle and an eventual temporomandibular dysfunction. Now, unilateral posterior crossbite, which is basically one of the most important characteristics of a pseudo class 3, has been statistically associated with mandibular distortion. So that means to say that a pseudo class 3 has a very good chance of developing TMDs. Now, there are many studies which have been done, and one of the very good studies has been published in the Journal of Applied Oral Sciences. It concludes that a class 3 is absolutely not related and does not cause any kind of TMD on its own. But at the same time, you can see the table over here, which says that there are relationships between occlusal contacts and TMD. Goes to say again that in the non-working occlusal contacts is what I'm talking about, on the non-working side. As you can see over here, if there is a non-working occlusal contact that is present, 70% have developed mild TMD. So now that goes to say that the contact on the non-working side is one of a determinant factor when it comes to developing TMD. It may be a class 3, it may be a class 2, it may be any kind of thing. But we are talking about contacts on the non-working sides, which actually cause a mild TMD. And according to this paper, it's caused mild TMD in 70% of the subjects. Again, another paper will show you that the prevalence of studied occlusal factor was higher in patients with moderate and severe TMD. Statistically significant results were found on absence of 5 or more posterior teeth. That is, if the teeth were missing, overbite and overjet greater than 5 millimeter, edge-to-edge bite, or absence of effective anterior guidance on the balancing side interferences. So these are some of the other occlusal or dentoalveolar factors which may be associated with a temporomandibular joint disorder. Now, as you know, the face group, which is currently guided by Dr. Domingo Martin and Alberto, is they work a lot on splints. Now, the idea behind their manifestation of treatments is that they actually provide splints, and when they put in those splints, they kind of guide the mandible into their ideal position or into their structural position, right? As we have discussed. So basically, what they're trying to say is that never believe what you can see on a patient. If you can see that a patient is probably with a class 2 or a class 2, a normal class 2, for example, or a class 3, the truth is that it may actually not be a class 2. When you actually put in a splint on the patient, you will notice that the actual position may be even a class 2 open bite for all you know. So that's what they say. Basically, you mount it on an articulator after giving a splint therapy, and then you would see the actual or the actual malocclusion. So they say that the actual malocclusion is always hidden. Now we try to replicate it in my university. Dr. Nadella was the one who developed this, and we call it the COTS protocol. It's the Center for Orthodontic Training Seminars. We try to basically disocclude the mandible and the maxilla. And once we disocclude it, what happens is, and I think I've spoken in one of the seminars and the lectures in Ahmedabad as well about this particular theory. This theory revolves around the fact that we disocclude the sevens, and now we confuse the patient into a different bite altogether. So now once the patient is not able to bite in his usual position, we confuse him, and then we guide the mandible into its proper position with the help of elastics and accentuated as well as reverse curve wires. Now, how we're going to be doing it is, I'm going to be demonstrating that in a series of cases. Now, what we're going to be doing, as you can see over here in this case, is that the patient has a very severe midline shift. You can see that the midline shift is more than about 4 or 5 millimeters. The distinguishing factor, as I have mentioned already in these pseudo class 3 cases, are a unilateral crossbite, as you can again see. Also, in this particular case, as the definition suggested, you can see that there is some kind of a problem with this lateral incisor here. This lateral incisor over here was probably the cause of the shift of the mandible. And over a period of years, this particular patient has developed into a true class 3. As you can see that the left side of his mandible has overgrown the right side of his mandible in this particular case, and which is now developed into a true class 3. But still, we try to correct his malocclusion considering that it is a pseudo class 3. So the idea is raise the bite on the sevens, and the bite has to be raised in a very rounded fashion, not in a very cubical fashion, because the cubical fashion is going to give him a static bite. I want him to be on a dynamic bite, which so we give him a very rounded kind of a bite turbo on the sevens, disoccluding. Now, as you can see in the CBCT of this particular case, you can see that there is distraction of the condyle on the right fossa. And you can see that dimensions left are absolutely normal. So this was in the beginning, and as you can see, we placed in the bite turbos, and now I placed him accentuated curve wire on the lower. Accentuated curve wires try to tip the lower teeth back, but at the same time, they intrude the posterior segment, especially the premolars. Now, what I could have done in order to stop this particular open bite was probably I could have used elastics from the very beginning and this increased to such an extent.
Adith? No. Adith, are you there? I guess we have lost the connection. With
Yeah, I am back. I'm back.
Okay, okay. Please share your screen.
Sir, so which part? From which part was it again?
It was just now it went. Just now.
Okay. So, yeah. From the CBCT, I think it was okay.
Yeah, CBCT. Yes,
and
perfect.
This stage.
Perfect. This
okay.
slide. The slide before.
This slide. So
just
what I'm
a slide before this. Okay, this one. Perfect.
Okay, right, sir. So now we are talking about this particular case of an example in which I'm going to be showing you how we have corrected this particular case of a pseudo class 3, which has traversed to a full-blown skeletal class 3. As you can see now, the left side of the mandible has overgrown the right side because this particular malocclusion was not treated early on. So now, basically, you can see that a heavy midline shift on the lower unilateral crossbite, and you can see this inset lateral incisor, which was probably the cause of the entire malocclusion. Now, in such cases, what we do is we raise the bite on the sevens, a rounded bite, as I have mentioned, and you can see over here in the initial CBCT that you can see there is a possible distraction of the condyle. There is an increased capsular space over here, but on the right side, on the left side, you can see that it's okay. So maybe resulting from this particular malocclusion. So we decided to probably get this treated and see whether that is affecting the temporomandibular joint in any particular way or not. So we have now increased the bite over here on the sevens. You can see that I have placed an accentuated curve of SPE wire on the lower. Now this particular SPE of wire causes some kind of tipping of the lower incisors, and at the same time I have guided the mandible to its right position using light elastics. Elastics used are 5x16 light. Now I could have stopped this open bite from forming by the use of some elastics here as well, but then I didn't do that at this particular stage because I was guiding the mandible to the right side, and I thought this is going to be easy to correct towards the end. So I moved into a rectangular wire, thick rectangular wire. This is an 1825 stainless steel, in which I'm actually correcting the curve of SPE and closing these small spaces. So basically the key is raise the bite on the sevens, then use these midline elastics. The midline elastics used over here is 1x4 medium. You can use the light ones in the beginning, and then you can jump into the mediums. And then this is a 5x16 light elastic because I'm still on a round wire on the lowers. You can see that the curve of SPE is deepening over here, and you can also see a gradual correction on the midline. Towards the end, you can see that the midlines have been corrected, and the thick night eye, it's a 1925 night eye that I've placed over here, settling the bite, and everything is okay except for the angulation of this particular canine, the right lower canine. Now, what I decided to do is, the problem is when the tips or the torques are exaggerated, it's very difficult to get them back by just filling in the slots. Because it's overcorrected in this particular case. So now I had to use something on the opposite. So I decided to use an upper lateral incisor bracket. You can see that the upper lateral incisor bracket has a positive torque, right? But when it crosses the down, if we use the same without inverting it, what's going to happen is it's going to push the roots out again. we have to invert this bracket, and that's going to give you a heavy, a positive crown torque on the canine. And as you can see in this picture in the finish, that the torque is overcorrected in the canine region. I was not able to correct the skeletal discrepancy at all, but yes, I was able to correct the joint space issue, which makes me feel that I was able to correct the TMD in this particular case. You can see that the post has ideal joint spaces and no more distraction is seen. Similarly, let's go on to another case. Dr. Ajay, do we have questions?
No, not yet.
Okay.
You so want to break for a question? You want to break for a question? We can just ask.
I don't mind. I don't mind breaking for a question.
If anybody is having a question for the cases which had shown right up till now, so it is better we can just make it a little interactive and
absolutely, it'll be better.
So if anybody is having a question, yes, we got a question here.
Okay, please.
What should be the joint space normally, Dr.
See, the joints. Now, exactly, if we see a particular joint space about 1 millimeter, especially on this kind of a CBCT, 1 to 1.5 millimeters would be ideal. But if you see a joint space which is increased at one dimension, like you can see over here, and which is constricted in one dimension, that means to say that the condyle is not seated. That may be because of some kind of a movement or a pseudo shift. It should basically be even.
Okay.
Right, sir?
Yeah. Okay. Yeah. There is a question from Dr. Tulsi Mahadevia.
Okay.
Just a minute. Yeah. Wanted to understand how to disocclude the sevens.
Okay. So basically what I do is I just place...
I request everybody to please ask a question in question and answer, because it becomes really difficult for me to read from both chat section as well as question and answer. I hope you understand, and please cooperate as well. Thank you. Okay, go ahead, Dr. Adith. Sorry.
Yes, so basically I prefer raising the bite on the terminal molars, and I usually give a bite turbo which is rounded. By rounded, I mean that when the person is actually trying to bite, he cannot fix his bite in any particular way. And so the effect of the elastics is more dramatic. The elastics are able to guide the mandible into the direction that we want it to move in a better fashion, rather than having a static bite turbo, which is usually the case if I just want to disocclude in order to stop the brackets from popping out.
Right. Okay. Can you hear me?
I can hear you, sir.
Okay. Somebody has raised the hand also. Dr. Allah Al-Mosawi, please go ahead. Please ask a question. I allowed you to talk.
Yes, doctor.
Yeah, please go ahead.
Hello, doctor. I can hear you.
Yeah, I want to ask about the most clinical feature. Clinically, how can I diagnose the Pseudo Class 3? What's the most common feature for diagnosis Class 3? Not.
Okay, let me just give you. Let me just tell you how I do that. Number one, if I see that on maximum mouth opening, if the mandible glides back to a coincident midline, and number two is a unilateral crossbite. If I see both of these together, most of the times it's going to be a Pseudo Class 3.
Okay. Thank you, sir.
Yeah.
Okay. The next question is from Dr. Arun Bosco. Would there be any change in mandibular body length if the Pseudo Class 3 is left untreated?
See, sir, if the Pseudo Class 3 has developed, and usually they have to be corrected at a very early stage, growing stage. If they are left untreated because of the malocclusion, probably because of this case, like I showed you, this guy would have probably had this lateral incisor in for a very long time. If this was corrected, his mandible would have corrected automatically, and there would have been no development into a true Class 3. But of course, if he has left it in that particular way, in that growth pattern, for say another 15 or 20 years, definitely it is going to move into a skeletal Class 3.
Okay.
And it's very difficult to correct by doing dentoalveolar measures and correcting a skeletal defect. That's not going to happen. You might correct the occlusion 100%, but the skeleton might not. You might still see a shift in the mandible. Like in this particular case, you can still see that there is the left side is bigger. There is still a movement, but inside it's on. Okay. Now we had very big doubts regarding these such cases and such treatments, because people used to, and I used to wonder myself, that what if I'm just correcting the dental malocclusion inside? Is it actually going to put too much strain on the temporomandibular joint? But then when we took those CBCTs, is when we actually got to know that not in all cases. We see that the head of the fossa, the head of the condyle is seated very well in the fossa.
Right. The next question is from Dr. Lee Hang. For first, do you place posterior biturbo on 4-7 or 3-7 and 4-7?
Both 4-7 and 3-7.
Right.
From the very beginning.
Okay. And
accentuated curve wires on the lower.
Okay. I'll just take 2-3 more questions. Dr. Raghu Devanna. As the cause was joint space problem, I think pseudo unilateral crossbite was established in the case. I think, what's your opinion?
I didn't understand the question, sir.
Okay, the question says that I think pseudo unilateral crossbite was established in this case, looking at the joint space problem. What's your opinion about
Absolutely.
it?
Yes. Most of the cases of pseudo class 3s have some kind of joint space issue, especially distraction on one side. So this has been probably a result of the unilateral crossbite of the pseudo class 3.
Right. Okay. Dr. Anupam Agarwal wants to know, you prefer CBCT or MRI for TMJ analysis?
If you want to look at the dynamics, then definitely it's going to be an MRI. But otherwise, for the joint spaces in particular or something. But if I just want to see the condylar head position in relation to the fossa, I would prefer a CBCT.
Okay.
Moreover, a CBCT is very convenient because we have a machine. MRI is going to be very hard.
MRI is better for soft tissue things.
Absolutely. So if it's a soft tissue disc, like retrodiscal tissues or something that I need to analyze, then an MRI.
Okay. The next question is from Xiu Yi Chin. Why the caries lower right 6 and lower left 6 not been removed to aid retraction of the lower LLS just now?
Okay, so very, very good question. Now I will tell you that, see, this is where the diagnosis comes into play. I have made so many mistakes with pseudo and true class 3s that there was this one time that the case presented to me similarly. And I did not diagnose the case as a pseudo class 3. The class 3 defect was actually so much, the canines were into about a 3 millimeter class 3. I was like, this has to be a true class 3. And then what I did is I extracted the premolars. And when I extracted the premolars, after leveling an alignment, when the premature contacts had disappeared, the case automatically came back into a proper class 1. So now I have class 1 canines, and then I have space distal to the canine as well. So it was absolutely a useless extraction to happen. Similarly, in this case, I did not want to extract the lower, the molars, because it would have been very difficult for me to correct the curve of spee, the curve of spee issue. I did not want it to just dump in more because I was using an accentuated curve of spee wire. And if I would have put that wire into the 7s would have just lingually dumped. Now it has some contact with the 6, so it prevents the lingual dumping, which is actually a consequence of the accentuated curve of spee wires. So anyways, the caries teeth were removed towards the end. And as you can see that crowns have been fixed. So absolute space has been maintained and the case has been corrected as well. So this is where I'm trying to say that please don't extract and jump and extract in a pseudo class 3.
Okay.
To start retracting, because you might not need retraction.
Right. The next question is about how did you reverse the lower curve arch wire?
By the use of elastics. See, once you gain positive ideal overjet, you could just use normal elastics and correct the bite by extruding the lower posterior.
No, question is how did you reverse the lower curve arch wire?
How did I do it?
Yes.
I just use a reverse curve. I use it the other side.
Okay, got it. The upper one you can use in the lower, something like that.
No. Any reverse curve, the reverse curve is usually like the reverse curve, and you just place it in the opposite fashion. So you get an accentuated curve rather than a reverse curve. Like the way you place it for deep bites, you place it the opposite.
Okay, next question is, Dr. Anuradha, only one side we have disoccluded. Is there will be not a
both
problem
sides.
by
Both sides.
Both the sides. Okay. Okay, Dr. Vishal, did the patient previously elicit any TMJ issues prior to orthodontic treatment?
No, absolutely not. The patient did not have any kind of issues, but we took a CBCT because we were trying to see that are we actually causing more problems or are we correcting it?
Okay. Dr. Raghu, what was your diagnosis in this case, skeletal or a pseudo functional class 3 with a unilateral crossbite?
It was a skeletal class 3. And I was trying to understand, and I treated this case like a pseudo class 3, and that is why I'm presenting. So it was a true class 3 treated like a pseudo class 3.
Right. Next question is from Dr. Raghu. What was your diagnosis in? Okay, it has been done. Dr. Himadri, how many days did you place the bite turbo?
About 3 months, I think.
Okay. And what is the chief complaint of this patient? What was the
crossbite?
Crossbite.
The shift. The patient actually had a chief complaint of his face as well, but I clearly mentioned that I might not be able to correct your face completely.
Okay, we have Dr. Sunanda ma'am with us.
Yes,
ma'am, please go ahead and ask a question. Ma'am.
Hello. Yeah. So
good evening, madam.
Good evening. My question, Adith, is how are you using this accentuated curve of SPI wire? I mean, what is the basis behind it? How is it helping? You are trying to deepen the bite and open the bite on the affected side?
So, madam, the logic behind this is because that when we use an accentuated curve of SPI, the understanding is that a pseudo class 3, as we know, tend to have proclined lower incisors and retruded upper incisors. So when we use an accentuated curve of SPI wire, it tends to upright the lower incisors, get them in back. And at the same time, with that particular accentuated curve of SPI wire, if you use a round wire, by the way, if you use a round wire, the side effect of the round wire is slight lingual dumping, which actually helps containing the lower arch within the upper arch. Number 2 is retroclining the lower incisors. And number 3 is the guiding, which we use along with those elastics together. So the elastics are independent of the accentuated wire. The elastics we can use also on a normal wire. But the logic is to upright the lower incisors and to also lingually tip the lower posteriors a little bit.
Yeah, so proclined lower incisors should be present, and that would normally be in a pseudo class 3 rather than a true class 3 where they are retro.
Absolutely. Yeah? True class 3 would have a different ball game altogether for treatment, where extractions would be probably of consequence.
Okay, thank you very much.
Thank you.
Shall we take a few questions or shall we go ahead?
Actually, we can, sir, because this will actually clear the logic. Okay. And the next few cases are very similar, so you won't have much of questions there.
Okay. So kindly describe about Splint for management of pseudo class 3. Some of the articles suggesting during class 3 correction, use Splint in the lower anteriors, but why? They suggest also in the case of class 2 placed in upper anterior, but why? I think this is more of a TMJ question which you
absolutely. So this is something like when it goes to the face philosophy, the understanding is that whatever you see in the mouth is false. They don't believe what they see in the mouth. Everything is false. So what happens is, I have also personally seen it. In one case, have I used a splint, a stabilizing splint, to get it into the CR position, putting it in a semi-adjustable articulator. I saw that a class 1 minor turned out to be a full-blown class 2 open bite after the TMJs were positioned into the structural position that is well within the glenoid fossa. So basically, that hampers our entire understanding of orthodontics, and it's a different ballgame altogether. If we go and treat cases like that, most of the cases we treat are going to be false. Because according to those guys, whatever you do and you take the TMJ in the end, the joint is that the condyles are not in the proper position. So
every
why
case will be first deprogrammed and then it will be
absolutely. And that splint is a deprogramming splint. That splint is basically used for the purpose of deprogramming and easing the condyle.
Yeah, it's all that is how Domingo Martin works, right?
Exactly, and that is why whatever we do is wrong, according to them. And think of the logical perspective.
You're not allowing your condyle to be free. You know, that's the problem. That's what he thinks.
Yeah.
Yeah, we respect it.
And he has also seen. He shows perfectly treat cases class 1 with a lot of pain, temporomandibular dysfunction, MPDS, and all things. So, which is a resultant of these treatments.
And he has a lot of evidence to back up also. So
absolutely,
right.
40 years of experience.
Yeah, that's what Dr. Asaf is asking. Do you expand the maxilla to correct the urinary crossbite, or it's just been corrected with leveling and alignment? See, here I'm not switching on my video also because it should not interfere with.
Absolutely, I think it is better. I think it is better.
Yeah.
Now the basic thing is I would use expander if needed. If the arches are very narrow, I use expander, and this is to do with the wires.
Okay. Dr. Ruchi is asking, is there any chance that pseudo class 3 reoccurs after correction of malocclusion?
There are studies again which say that the best indicator of correcting a pseudo class 3 is the most stable way is by getting the upper incisors forward more than the lower incisors behind, and they are more stable by nature. There have been cases, and there is a very good study, I think, in Anchorage that there is a relapse tendency in pseudo class 3s, but it depends on kind of treatment rendered.
Okay. Like you, in most of the pseudo class 3 cases, you had a midline shift?
Yes, sir, I do. Because there is a guide in the mandible. There is a shift.
Okay.
Unilateral crossbite.
Okay. Please give us 2 signs of diagnosing pseudo. I think you had already told about pseudo, how to diagnose.
Exact 2 signs. Yeah.
Okay.
Yes,
Dr. Vipul Sharma is asking why you have not used splint to show actual asymmetry initially.
Why didn't I use a splint?
Yes.
I thought it was pretty evident from the very beginning. Because my way of probably diagnosing a pseudo class 3 is, as I mentioned, mouth opening and shift and looking at the midline shift. So it was a very clear indicator for me that it was a pseudo class 3 from the very beginning. It's traversed towards true class 3.
And what is your preference of regular radiograph? That is lateral ceph, panoramic, CBCT? CBCT you include in every patient or only as and when needed?
No, sir. I include in all patients.
Okay. Right. So in such cases, what should be retention protocol? What is your retention protocol?
The protocol in such cases, I just place a regular fixed lingual retainer along with clear Essex retainers on the upper, and proper intercuspation and correction of the overjet, a little bit over correction is much better.
Okay. What is your take on cases where there is a macroglossia, or you think that the anterior tongue positioning is there? Would you like to extract in such cases in lower?
If you have a macroglossia or a low tongue posture, it is already an etiology for a true class 3. But a macroglossia definitely would go in for a glossectomy, some kind of a glossectomy. Otherwise, extraction and tongue position, we have to correct the tongue position first, and extractions are not going to be dependent on that.
Okay.
because we have to correct the tongue and place them high up in the palate first.
What is the width of that splint, sir? And what type of splint it is needed? What is the width?
I use the width.
Yes. Dr.
This
Adith,
standard. It's regular, like it's like it's the occlusal, and there is no particular dimension on that actually. It's like regular stabilizing splint.
okay.
There's nothing very different about it.
Do you use, what is your take on using articulators in orthodontics, particularly in TMJ cases?
Very, very, very few times have I used it. I have to start incorporating the use of articulators in orthodontics, especially after seeing those group of people who get wonderful results, especially. I currently, I use it in maybe 1%, less than 1% is what I would say. But I think we have to start with phase-board transfers, articulators, in order to get functional stability as well.
Okay. I'm taking the relevant questions, one or two now. How did you correct the root prominence of 4-3?
So what I did is I took the upper incisor bracket and I reversed the upper incisor, lateral incisor bracket. And so now this upper incisor bracket will give you excessive positive crown torque on the lowers. And I filled it in with a 2125 stainless steel at the end for about 2 months or 3 months.
I think we can go ahead with the next section now. We are done with the relevant questions.
Okay, sir. Right, sir. So now moving on to the next case, and the next few cases are almost pretty much the same. This is going to give you an idea of how I correct these last three. So moving on, again, a young girl with a huge midline shift, no unilateral crossbite, as you can see in this case, right? So they come in different clinical features, but in this case, how I diagnosed it was again maximum mouth opening, and I saw that this particular the lady, she started to get her jaw into the facial midline when the mouth was open at a maximum mouth opening. So I decided, and you can see a big class 3 canine issue over here as well as over here, molars. But still, I did not want to extract in this case in the beginning. So I decided to first of all correct it with the bite turbos and the guiding, and then move in to let's see whether we would still need or not. Now, please try to see that she also has a shift in the mandible, and you can see that there is a shift towards the right. Now, because she was growing, I still have the notation of maybe this case has not traversed into a full-blown class 3 yet. So I decided to now raise the bite again at the posteriors over here, and then what I did was, in this particular case, I used class 3 and class 2 elastics. Class 2 elastics over here, as you can see, this is, I wanted to correct the class 2 issue. And over here, I used class 3 because it was a canine class 3. So you can guide the mandible in any particular way. You can use maybe class 3 elastics and a midline elastics, or a class 2, class 3 elastics, or any kind of fashion that you want to. Now the elastics used over here were 5x16 elastics, light elastics, and going on to heavy elastics as and when the wire as you see, and in just 9 months, I was able to face for class 1 with coincident midlines. Now, that also you can see that the midline, the mandibular asymmetry has been corrected in the facial pictures. So we were able to stop the progression of this particular case from going into a full-blown class 3 by just using simple modalities like I have mentioned before. Similarly, we have another case which is a little more severe. Now, this particular case was a little more severe because she didn't have teeth. Now, because there are no teeth, it becomes very difficult to raise the bite and also give the elastics. Now there are crowns over here. See these crowns. I didn't want to take these crowns out. I wanted to first try to get the mandible in. You can see that there is still a shift mandible in this particular case. I use the elastic in this particular case. I use elastic class 2 fashion and the midline fashion in order to get the midline. Now, what happened in this case, she also had some kind of a tongue thrust. I placed in a crib as well. On this case, in order to the tongue thrust issue. In about a year's time, I was able to get coincident midlines with proper class canine classifications in this particular case. Now it became difficult for me to actually engage the elastic over here because I didn't want too much of a horizontal vector. So I decided to place a small crimpable hook and use that as my anchor for the elastics. And of course, when you do this, you tend to slide the wire forward, and that's why I had to actually flush this crimpable hook with this particular lateral incisor over here in order to prevent the sliding of the wire ahead. Now, again, one more similar case over here is you can see a heavy midlift over here, and similar modality used. Raise the bite on the terminal molars, rounded bite, confuse the patient, give class 3 elastics, mid elastics, and then over about 6 to 7 months, I was able to change the neuromuscular in the patient and get him into a proper class, midline, coincident midline. And after which, all I had to do was to close the space. So I used closing loops on a 1925 stainless steel, got the lower inside, and the case was again corrected into a proper class 1. So again, this case had already traversed into a skeletal defect, and that's why dental correction was possible, but the skeletal correction was not possible. As you can see over here, once the case was finished, again, the spaces have been evenly matched, as you can see over here, showing that the treatment has not caused any particular distraction. As you can see from the superimpositions, minimalistic teeth movement has taken place in the upper, which is almost maintaining the uppers where they were, but the lowers have gradually just tipped behind in order to correct the pseudo class 3. Finally, I would like to move on to the last discussion of the case of a pseudo class 3. A young guy again, and rightly he came in at the right time, probably 10, and I was able to correct his occlusion, and this in very, very big asymmetry probably later in his growth spurts. Now, these cases are very tricky. You see that this left incisor over here is absolutely obliterated by this particular segment, which is extruded in the lowers. So ideally, we are supposed to intrude this segment. And I know that the fault does not lie up with the uppers because I can see the gingival margins are almost constant. If this gingival margin would have been lower, I would have known that this particular tooth may have been extruded. But in this case, it's very clear that this particular segment is the one that is extruded. Now, I have treated this case by raising the bite lingually on only these 3 teeth. To raise the bite, unfortunately, I don't have the pictures of that. But yeah, I have raised the bite exactly here and here, so that the bite could be opened, and then I tried to tip this particular tooth out. In just about 6 months' time, I was able to jump the bite and automatically everything fell in place. The other option and the alternate would be to do something like this. You see, screws and intrude only that aspect. But there is a side effect of using mini screws with segment technique is that there is no anchorage, and the anchorage, without an anchorage, all these teeth would buckling of these teeth is one of the side effects of using such mechanics. As you can see over here, the canines have flared, and then you have to push them back again. But it's up to you. You could use teeth mechanics as long as you know how to control what's going to happen. At the end, I was able to correct this particular case in just about a year's time without actually causing much of an issue. And I'm sure that he's now going to be stable into a class rather than develop into a class 3 later on. Do you have questions?
Let me check.
Almost the same philosophy that I've been using on all these cases, just to give you an idea of how to actually diagnose a pseudo class 3. Very simple cases. All you have to do is just jump the bite, clear the premature contacts, and
Okay.
then you're
How,
good to go.
the question says that how did you raise the bite in the case with the missing teeth?
With the missing teeth.
Yeah.
Here.
Yeah.
Yeah. I've raised it here at this terminal molars.
Both the side.
Yeah, both the sides. Both the sides.
Okay. The next question is when you need a positive torque, why should lateral incisor bracket be reversed? It was already having a positive torque.
Yes, absolutely. But when you go for a positive torque, please understand that there is a positive torque. And when you don't reverse it and you just go down and place it in the same angle, it is going to push the roots forward more because it's still positive. But it's the upper bracket.
Right.
And so you have to reverse.
Okay. The next question is, if there is no abnormal tongue etiology and moderate reverse class 3, reverse jet with the class 3, patient will be having habit of lower tongue positioning, and you extract lower premolar to correct it. What about retention and relapse? What will be your retention protocol? I think that has been answered, no?
See, if there is a tongue issue, I would definitely use a tongue spur on the lower incisors in order to correct the tongue first of all. And when I'm very sure that the tongue has been corrected and is going to not come down anymore and is going to stay up on the palate, is when I'm actually going to see whether extractions are needed in that extraction help or not, etc.
Okay.
The retention protocol would be maybe to maintain the tongue spur with the retainers itself in order to avoid the tongue from pushing the teeth again.
Yeah, I think Dr. Malvi Thakur, your question has been answered. Even then, I think let me repeat because you might not have heard him because of the audio disturbance. Like you can use a tongue spurs in a retention protocol as well, so that your abnormal tongue posture or repositioning would not lead to any further relapse. I hope it is clear with you now.
Or you could use you could also use a holly. You could use any kind of you can use any kind of tongue grip as well.
Dr. Raghunath wants to ask, what bracket prescription was used in pseudo class 3 cases?
I use, I mean, there is no particular prescription that I would prefer. But usually I use MBT and I use Damon as well. So it is not, it's not particular to a pseudo class 3 or anything. You can use anything.
Okay. Dr. Zarina Bali, she's asking, do you prefer bondable spurs? I think there's nothing wrong in using it. Yes.
I do prefer bondable spurs. They're very aggressive though, but it works wonders.
Yes. Okay.
I've had patients coming with bleeding the subsequent appointments, but still.
Dr. Alexis Chan, for the young boy case, do you raise the bite on the opposite side? I think both the side you raise, no?
No. In this particular case, I haven't raised the bite on both the sides. I've just raised the bite on the lower anteriors.
Okay. Okay.
Just to get this at the same time through these teeth. So I actually placed them 1, 2, 3 here.
Right.
For just 1 or 2 months, got this out as soon as possible because or else this would go mobile.
Okay. If yes, then like if you're using a tongue spur, then on maxillary or mandibular teeth, where do you prefer?
Mandibular.
In case of class 3 mandibular.
Low tongue position. Lower anteriors.
Okay. I think there's a problem with your network. but that's fine.
Again.
What is the reason of using class 2 elastics in one of the case?
See, there is, it's not that there is no hard and fast rule that you have to use only class 3 elastics and then class 2 and midline elastics. You can use any elastics depending on the canine classification. The idea is just to guide the mandible. Even this class 2 and class 3 width is going to guide the mandible towards the left of the patient. So that's okay.
Right. Okay. SP ICP examination, cranial base length, upper one to palatal plane, and IMPA angle. Major differential diagnostic factor between pseudo and true class 3. What's your take on this?
Let me just hear the question again. So it's too technical.
Okay. With the cranial base length,
okay,
right? Then upper one to palatal plane.
Upper one to palatal plane usually is retroclined. The teeth are usually retroclined. Upper.
Yes. So what
IMPA is usually proclined.
So he's asking that can we use this as a differential diagnostic factors between pseudo and true class 3?
Yes, you can. Of course, you can. A true class 3 almost always never has proclined lower incisors or retroclined upper incisors. It's almost always the other way around.
Okay.
And also, you will never find vertical defects, especially when it comes to pseudo class 3s, early pseudo class 3s.
Dr. Adith, do you prefer to bond both the arches together after putting the bite turbos in class 3 cases?
Yes, yes, I do. Because I give the elastics, right? So I need the interarch control.
Okay. Can you repeat what was the most important criteria in diagnosing the pseudo class 3?
For me, the most important diagnostic feature of a pseudo class 3 is maximum mouth opening, where the mandible tries to shift back to the facial midline and gets coincident with the uppers and the facial midline. That's number one. And number two is there are about 70 to 80% of the cases I've seen unilateral cross bites.
Okay. Sir, in pseudo class 3 cases, patient will represent a deficient maxilla in safe, and even clinically. Why would they present with a deficient maxilla in pseudo class 3?
No, they usually don't manifest with a deficient maxilla, but they would maybe show up with a concave profile.
Exactly. But not,
that is because of the incisors. That is more to do with the incisors than the skeletal pattern. Yes, absolutely.
Yeah. Okay. In case, in the case where you had placed bite on the lower anterior teeth, why didn't you raise it on the posterior? Any specific reason for that?
Because the specific reason over here is very clear, that the problem was intended to be solved on this area alone. So I had to place the bite over here, because if I would have placed the bite at the back, it would have been too much to open. As you know, the scissor effect, right? So this is almost covering 2/3 of the crown. To raise this much of the bite, I would have to at least, 3 millimeters or 4 millimeters of bite turbo, which would actually really cause a big posterior open bite for him to jump this particular bite. So I decided to just use it over here immediately, because what I can do is I can just place a wire straight away and get this tooth out, flare it out, and then immediately take off the bite turbos. So I feel that you could have also raised it on the back teeth. I mean, looking back at it right now, I don't think it would have made much of a difference even if I would have raised the bite at the back.
But it was your individual preference to put it.
Absolutely, you could do that in this case.
There was no specific rationale for
no
that.
Specific, right? No specific reason for that.
Okay, thank you. Go ahead. I think we are done with the questions as of now.
Okay, so that so with that we conclude our pseudo class 3 session, and now we will go on to true skeletal class 3s. So now this is a little more complicated than pseudo class 3s, because here the problem is more skeletal than dental, and almost all the treatment that we render would be bracketed under the realms of camouflage. So ideally, most of these cases would be surgical, but we would treat them in our offices, dentoalveolar, and with some amount of compromise. And almost all these cases have some compromise among them. Now, features of a true class 3 would, of course, be a concave profile, class 3 skeletal pattern, no premature contacts as you would see. You would see a forward path of closure again. Your gonal angle may be increased or decreased, irrespectively. Retrusion of the mandible is not possible. In the sense, what I'm trying to say is you can't get your teeth back to an edge to edge properly. Proclined upper incisors and retroclined lower incisors are basic compensatory factors which are seen in true class 3s. So I'm going to start with a very easy example of a true class 3. Now, in this case, why I diagnose this with a true class 3 is she's again a young girl, but you see the mandibular position, it's high. It's a high angle mandibular position with coincident midlines and no shift of the mandible on opening or on rest position. So this makes me feel that she is a true class 3. As I said before, there's a very thin line between a true and a pseudo class 3, which has to be identified. And why is it very critical to identify that? Why can't we just treat everything like a true class 3? I mean, a very, very feasible question that was asked to me. And I myself asked this question many times. But then comes the question of extracting. And when I had extracted in a pseudo class 3 is when I realized the importance of diagnosing it. That sometimes you can just avoid extractions. So again, in this case, I deferred from using a face mask because of the high angle. I don't want to increase the angle, which is usually the situation when we use a face mask. So I just bonded the uppers, tried to move the upper ahead, and over a period of time, bonded the lowers. And a very simple case in which we just settled the bite, made some space for these peg laterals, which were beneficial for our class 3 because we could procline the upper incisors a little more. And in the end, in this case, actually, I have moved the canine into the place of the lateral incisor and substituted it. The word for this is canine substitution for a lateral incisor is what I've done. We have to change the brackets because the torque has to be changed. So what I did was simply I placed a lateral incisor bracket on the canine to get the positive crown torque. And towards the end, some amount of enameloplasty is definitely needed when you tend to use a lateral incisor bracket on a canine because the curvature does not allow the bracket to absolutely fit. And if you don't, you will have a lot of pop-outs. So you have to maybe just use a burr and flatten the surface of the canine a little bit in order to fit the lateral incisor bracket comfortably. Over a period of time, I could see the roots going in and the crowns coming out. And then finally, we made some space and built up the canine lateral on one side because this was peg-shaped, and this side we corrected the, we did a lot of IPR and reshaped the canine and made it into a proper lateral incisor. As you can see, the bite is okay. And I was able to correct her class 3 issue in a very in a very simple way. So it's more simple, and I didn't try to get it more complex by getting in a face mask and all those things. So these are simple cases which can be corrected this way. I showed this case because of the lateral substitution, which made it a little different from the others. Implants placed on this particular area are usually very detrimental for the aesthetics. Lateral, because the bone over here is very thin, especially on the lateral incisor area. Any questions, sir?
Questions, let me check. Do you use ACS wire in all your cases having pseudo class 3 when raising the bite? If so, how long into your treatment will be using this wire? For how long you will be using this wire?
I use the wire till the time I jump the bite, and my objectives of gaining ideal overjet have been accomplished. Right. If I feel that the lower incisors are over retruding, I will stop using them.
Right. Okay. Done.
Now, This is a very, very nice paper to read by Dr. Bowman. It's Uno dos tres.
In fact, he is one of the speaker for day after tomorrow.
He's
that's what I was just writing. That's what I was just writing in chat section, that if sometimes, you know, people may not know what is the potential of Dr. J. Bowman.
Oh, J. Bowman is he's just one word. He's a legend. You name it. He's a very good friend of mine. In fact, I published two papers in JCO, which are coming out this May. In the June. It's on orthodontics in the COVID-19 era, which speaks about all the clinical nuances and what not to be done, what would happen if you use reverse curves and all these things. So it's a very interesting paper. I really suggest most of you read the part 2 of it rather. That's co-authored by Dr. Bowman as well. And
that's what we were, me and Dr. Adith were talking, like you ask anything and Dr. J. Bowman will have his own paper on that topic.
That's the best thing. He's like, oh, distalization. Okay, read this, 3 papers. And then I see the author, the first author is Bowman again. And then, okay, class 2, okay, he has papers. Distalization, he has papers. Aligners, he has papers. So he has more than 150 published papers. Come on, he's a great guy.
Amazing. Very true. Don't miss it for anything.
So, okay. So must read this paper. And in this paper, it's a very interesting paper in which he has actually spoken about the versatility of palatal implants with transpalatal arches to correct class 1, class 2, and class 3 malocclusions. So I'm going to be taking one case out of his wonderful paper to elicit the use of that mechanics. Now, this particular case is flat face, concave profile, class 3, true class 3. And because there was no shift in the position of mandible, no guide, etc. What he did is he placed these implants between the premolars and the second premolar and the molar. This is the best place to position it because you see that the roots of the premolars are usually a little buckle, and there's very, very less chance of actually hitting the root in this particular area. You can use a long implant, a 10 millimeter implant, to get good amount of stability. You can see it's a very simple transpalatal arch design with these hooks at the back in order to anchor the elastics. And these mini screws, in fact, are clear of the roots, right? So it's something like placing an IZC, but on the inside. And this would exactly work as an IZC, mind you, and it's very easy to place. So what I also do, I have used this in many of my cases and it has worked wonders, is you can protract the entire maxillary arch. So isn't it very simple? It's a very simple design to just place 2 implants over here, use a TPA. In this case, you can also intrude. You can intrude because you're acting at the center of resistance. So you're intruding perfectly your molars. At the same time, you're protracting the entire maxillary arch in order to get a good correction of a class 3. And as I have mentioned before, proclination or protrusion is more stable than tipping the lower teeth back. As you can see in this case, the same thing has been done, and you see the end result, a perfect class 1 occlusion, and you'll see that the roots of the upper incisors are also well within the bone. As you can see, no root prominence, and the profile, of course, you can't change a profile too much when it comes to a class 3, but still there is a lot of improvement in the profile, and such a simple method to be used. So this is definitely a takeaway, and I would urge many of you to start using this in your class 3 cases, along with considerations of lower distalization or extraction. But definitely, if you see some amount of issues in such cases, if your anteriors are not very proclined, again, if your anteriors are not very proclined, the uppers, you can go in for this. And this is also a very good treatment modality for pseudo class 3s. Go ahead, sir.
Yeah, one question. How do you retain skeletal class 3 cases treated orthodontically? Do you give Howleys only, or reverse Frankel or Bionator or chin cap?
No, so I don't use reverse Frankel or Bionators. I do sometimes use inclined planes on my retainers sometimes, but the ideal of most of the cases that I've treated, I've just in overcorrection. Overcorrection is the best possible retention. Even in Tweed also, that is the only thing that is basically taught to us, that whatever cases you do, you have to expect relapse and you overcorrect.
Okay, go ahead. Good to go.
Right. So now this is one of my very favorite cases, which I usually quote in most of my lectures. Now this is a high angle case of a young boy who was actually misdiagnosed. Now when I received this particular case, I'll show you the case, and it's a very different scenario from how it started. Now this particular case was, you can see heavy amount of crowding on the upper, narrow maxillary arch. You can see crossbites. On both these sides, you can see lowers, deep curves, peak crowding. So definitely extractions have to be involved. But at the same time, it's a super high angle mandible. This has to be corrected by probably the use of a high pull headgear in order to auto rotate the mandible, maybe some extractions in conjunction with surgery. And that would be my kind of diagnosis for this. But unfortunately, the doctors, they extracted the premolars, yes, rightly so, but what they did is they did not control the mechanics. They basically ran the wire from the molar to the canine, to the lateral, to the central, and so on the upper and lowers. And what basically happened was that this high canine and the crowding pulled the lower molars forward. And now they lost 100% of anchorage with a big class 3 and an open bite. And this is how I received this case. So now he is 18 years old. He has a super high angle mandible. He has such flared teeth, they're almost like they're on the floor. And when I saw the OPG, I was surprised to see that there are no roots on the upper teeth. For a minute, I was under the impression that did the roots actually resorb so much, because he was already under treatment for 4 years. I mean, you won't believe it, 4 years. And my first impression was, I'm sure that he has lost his roots. But then, just to double check, I went in for a CBCT. And in the CBCT, I actually saw that there were roots, but they were pretty flat. And when on palpation, and you won't believe it, I'll show you the superimpositions later. You won't believe it that I could palpate even the apex of the root on the palatal surface. That means the roots were absolutely out. I had to literally check for the vitality. And fortunately, they were vital, but the situation was very, very bad. Now, why the situation was bad is because of the fact that there is no bone on the labial surface of the incisors. As and when the teeth started to procline, remodeling has taken place, and what happens is you've lost bone in the front because that becomes your tension site. And so what happened is that actually got the bone out, and now I'm in a situation where I have to tip the teeth back, push the roots out, but I don't have any bone there. So I was even under the considerations that is it possible to actually use some bone grafts over there, wait for some time and get things done. But the patient's mother was in such a situation. You can imagine, I mean, your child going through an orthodontic treatment for 4 years and ending up with such a result. What would you do? And can you imagine my position as the new orthodontist over there? I was under tremendous amount of pressure to do something. So I had to think of some kind of mechanics to make things work. So what I decided was I'm going to be using very, very light forces. My first agenda would be to get this lower within the upper. So that means I had to correct the class 3 canines first, and then I would overcorrect the overjet, and then I would tip the upper incisors back a little bit. So what I did was exactly that. I placed a lower 1925 stainless steel. In progression, the lowers didn't need much of leveling. Maybe after about 3 months of leveling, I jumped into a 1925 stainless steel, placed in buccal shelf implants, and then I placed the hooks. I tend to usually place 2 hooks, one distal to the canine and one mesial to the canine. Usually you would see just one hook mesial to the canine. My logic behind this is, even though the wire is pretty stiff, the distance between the shelf and the screw anterior is too much and has to pass through a curve around the canine. And I have noticed in my case most of the times that this power chain goes into the gums and it lacerates the gums. So I decided to place it behind the canine in the initial bits of it, retract a bit, and towards the end, go to the front and engage it here. And when I engage it on both, I divide the forces. I don't use more than 300 grams of force per side. So 150, 150, or just 300 over here in the initial bits to distalize. As you can see, in the second, the third, fourth month, I was able to distalize the lower dentition considerably, upright the canines as well to get a class 1 on both, and I'm inching into a class 1 molar as well to the back. Overcorrection of the overjet, and later on I decided to place the brackets. Now this is an 014 night eye, and I decided to place elastics because I wanted controlled tipping. So I decided to place elastics from the upper canines onto the lower buccal shelf. If I were to place the elastics from the upper canine to the lower molars, this would have been meaningless. I mean, I'm trying to distalize, and then I'm giving a protrusive force again using the elastics. So I use the buccal shelf as anchorage for the elastics as well. And as you can see, over a period of time, I was able to get good amount of distal tipping on the upper incisors, and such light forces allowed me to remodel the bone as well. And over a period of time, I jumped into a 19 by 25 stainless steel. And as you can see, I have added on the distal inclination by reversing the upper 4 brackets, positive 14 on an MBT into minus 14. You have to be very careful because there is no bone over here. So every month, every 3 weeks, you have to keep palpating and checking whether you're not ending up in a dehiscent sort of fenestration situation, which is going to be very bad. Because you already have a headache upon your hands, and you don't want to create another one by exposing the roots absolutely over here on this side. Be very careful, but still it's possible. And in the end, I was able to get a very good dental relation, but unfortunately, you see, the angle of the mandible is not correctable. It is an absolute surgical case. I tried to convince her a lot for surgery, but she was not into surgery. Probably she lost faith in dentists after what she had undergone for her child. But anyways, I was able to give him a much more aesthetic appearance on his smile, and you can see the amount of distalization is considerable. You can see the relationship of the second molars over here with the second molars, and now you can see the relationship of the second molars with the second molars. A considerable amount of distalization on the lowers has taken place. You can see the amount of control tipping that has occurred over here. You can see also here that the apex of the root is exposed, and you can see the good amount of controlled tipping that has taken place to correct this particular case. So in the end, it happened. It was possible to do this, but ideally, again, surgical. But there was a very hard case to treat. So this is what a true class 3 goes into. You need a lot of mechanics. You need to think a lot. It's not just leveling the arches, getting rid of the premature contacts, and things just fall in place. It's much more than that when it comes to a true class 3. Do we have a question, sir?
Let me check. What about the late mandibular growth in these cases when then which are treated?
Absolutely. So late mandibular growth for me has been with history. Now, you see, this particular case had a history of being a class 3 from the very beginning, but it's not a Habsburg jaw kind of a phenomenon. You have to tell the patient, you have to be very clear with the patient that if the class 3 is running in families, there is a very good chance that after the age of 18, you would see late mandibular growth. Especially a determinant of the late mandibular growth would be lower incisor crowding. So if you start seeing something of that sort, you can assume that there is late mandibular growth taking place at that particular point. I always tell my class 3 cases, which are about 15 or 16, that they can expect late mandibular growth. What I usually do is I leave the buccal shelf implants inside for retainer purposes. I engage lingual buttons on the canine areas of the Essex on the lower, and I ask the patient to wear light elastics at night from the buccal shelf onto the Essex retainer to retain or to overcorrect it. And over a period of time, I ask them to wear it just once or once in 2 days or something like that. But I don't take off the buccal shelf implants for at least the next 2 years in my retainer program.
Okay. Next question is, did you measure the force clinically for giving power chain for distalization?
Absolutely. I use a Dontrix power gauge, and I always use a Dontrix power gauge, and I measure 300 grams of force.
Okay. The next question is about, it is advisable to use BSS in mild class 3 cases?
BSS means, sir?
Buccal self.
Buckle. Okay, buckle. Yes, of course, of course. This is a full-blown class 3, by the way. This is not a mild class 3. This is a pretty severe class 3, and I had to use a buccal shelf implant because you can see there's already a premolar missing, right? Because of the retreatment issue. So I kind of
Got it.
had to put it down.
I think there is a problem with your network.
I think it's better. Is it okay?
Yeah, that's fine. Dr. Raghu wants to know that IMPA looks more compromised in this case. Yeah, it was a camouflage. So.
Yes. No, one more thing I would like to clarify is whenever you see IMPA, IMPA is always a function of your FMA. That's what we are taught in TWEED as well. So it's not always that the IMPA needs to be 90 degrees. The higher the FMA, the more retroclined should be the IMPA for more stability, because it means that your teeth have to be perpendicular to the basal bone. It need not be, what I mean to say is, if your FMA is basically higher, the IMPA will be more retroclined. It's going to be 80 degrees for a 30-degree IMPA for FMA. A 30-degree FMA would not have a 90-degree IMPA stable.
Okay. Question is from Dr. Anuradha. So even if you have reversed the bracket, also there will be a torque which is negative. So how it goes with no impact on the teeth, anterior teeth?
No, it's the opposite of what you're saying. Upper anteriors have positive crown torque. In MBT, about 14 degrees of positive crown torque. So when you reverse it, becomes the particular case was such that the anteriors were too flared. So I had to reverse the torque. That's why I had to get the lobes in first.
Okay. Well, what was the situation?
If I would have treated the uppers first, I would have ended up in a harder anterior crossbite.
Yes. Okay. What was the situation of labio-alveolar bone in maxillary anterior region post-orthodontic treatment in this case?
There was a good amount of bone which was formed ahead of it because of the very, very light forces and continuous remodeling. The key was that we needed to have I was thinking of bone grafts, but it was actually not needed. And even clinically, you can see that there is absolutely no root prominence.
Okay. How do you manage with the lingual rolling of the molar while distalizing with a skeletal anchorage? And how do you minimize the dark triangles in lower anteriors?
So usually you might find some amount of lingual rolling, which is rightly said. The stiff wire usually takes care of that with the top prescription of your molar tubes. But sometimes you still don't have it. And in the end, you might have to use some crossbite elastics. The the black triangles can be usually addressed with interproximal reduction towards the end. It's beneficial if you have triangular teeth, but unfortunately, if you don't, then for me, the only option is veneers.
Okay.
You can go for intrusion of the incisors, but it's not always possible. It depends on the display.
Okay. Should bite jumping be done prior to, irrespective of case, being pseudo or true class 3? I'm a little confused in this.
See, in this particular case, it was paramount for me to jump the bite first because of the situation of the case. But there are cases in which I leave the bite jumping to the end in true class 3s. I make space distal to the lateral and lateral, and finally use a closing loop and jump the bite. Correct the posteriors first. In pseudo class 3s, I tend to do it in the beginning.
Okay. Can you please explain again about the protraction of maxilla using that TEDS, palatal TEDS?
Yes, of course. You see, This is the mechanics involved. This is the screw. The screw is about 10 millimeters in length, and it is placed at about 60 degrees of an angulation. There is very, very less chance of you hitting the root in this particular region. You have to make a TPA design. You can take a screenshot of this, by the way. Dr. Bowman would not mind. And then, you have a TPA. You have a hook which is fabricated. It's a very simple design. And all you have to do is you have to put a power chain. So this is pushing the back teeth, which is pushing the front teeth, which is going to push this and get it ahead and protrude and protract the maxilla.
So
maxillary teeth.
It is intrusion and protraction.
Absolutely. In this design, it is intrusion and protraction. In this design, it is only protraction.
Okay.
I'm sorry if I said protracting the maxilla. No, you're not protracting the maxilla. You're protracting the teeth.
Dentition.
Dentition.
Okay. While using IZC and BSS, that is infrazygomatic crest and buccal self screw, it's sometimes, you know, what happens is I'm having residents also, no? So few languages I'm also understanding now. When they present a case, they would say IRT. First, I was thinking, what is IRT? Then they explain in relation to it. So now I understood the language a little bit. So do you use TADs in anterior or heavy arch wire with accentuated curve or torque in anterior or pre-torque wire? Confusing question. Should I allow him to talk so that he can
Absolutely. I think that would be better.
Okay. Okay. Dr. Gopilal, I think he is from Manipur or from Tripura. I don't know. Dr. Gopilal, you are allowed to talk. Please go ahead. Please ask the question. You're from Tripura, Manipur?
Yes, sir, from Manipur, sir.
Okay, go ahead.
Sir, while using the BSS or IGC screw, sometimes I find it very difficult to control the torque actually. So I'm losing the torque a lot. So it is advisable to use the TAD in the anterior region or like, you know, heavy archway?
I think Dr. Gopilal,
absolutely.
If you have attended Adith's first lecture, first webinar, it was on this topic only, and where he has really mentioned with the clinical evidences like what he is doing it. Go ahead, Dr. Adith, please.
See, Dr. Gopilal, good evening. I would like to this is a very nice question. Even I have found a lot of issues. Now, there are many variables which are involved in it. First of all, which wire are you using for distalizing?
So I use 1925 SSS with the with a curve of speed, but sometimes
with a curve of speed.
Yeah, sir.
Okay. So it is very unlikely that with a 1925 you lose torque. Which prescription are you using?
So
are you using Damon?
Yeah, some Damon, and I'm using my selfie from the.
So usually the problem with self-ligation brackets is that the slots are bigger, and the play is just too much because of the fourth slot.
Okay.
Right. So now that usually you lose a lot of torque over there. So a 1925 or a 2 mil difference that you're thinking of is actually not a 2 mil difference when it comes to that, because the fourth wall is passive. It's a passive self-ligation system. I think you would find benefit in using regular brackets. Okay. Number two is that you can use accentuated curves as you're already using on the upper, as you mentioned. Number three is you can torque the anterior wire. You can torque the anterior wire, make a small twist in the positive ground torque direction, which would give you an intrusive and retractive vector itself. According to Dr. Lee, one of his papers in the angle, if you give anterior root torque, anterior palatal root torque while retracting, you get intrusion as a side effect also, which is usually beneficial in class 2 cases. I think these are the only things that can help you. Otherwise, I mean, I use the same. What you said, I use exactly the same. I might now, let me come on to the second part of your question. Would I use an anterior mini screw?
Yes, sir.
I avoid it as much as possible. But if really my incisors are upright from the very beginning, Do you understand? From the very beginning, they're not proclined and they're upright in position. Then I would consider using a third implant in the front. But if my incisors are proclined to start with, I would not use them. I would just go with the torque, see whether we are losing anchorage, torque it. But if I have to begin with retroclined or upright incisors, I would go in for a third TAD.
I think it's clear, Dr. Gopila.
Yes, I got it, sir. I got it, sir. Thanks a lot, sir.
Thank you.
Yeah.
Okay.
Thank you.
The question is about when you're using buccal self in class 3 cases, we tend to get a lateral open bite. How to overcome this?
See, exactly. One of the reasons why I start using two hooks is because, as I mentioned, in my clinical evidence, I have seen that no matter how stiff the wire, you still have bowing, vertical bowing. Now, one of the reasons I suppose you would have a posterior open bite is because of lack of sliding. You better check your posterior buccal tubes, whether you have actually placed the right buccal tube. Sometimes in our inventory, we tend to place 1/6 and replace that with 4/6, 4/6 with 1/6, 2/6 with 3, something like that. What that does is that reverses the torque over here, and that actually creates a lot of problem with sliding. So when there is no sliding, can you imagine that go from the buccal tube and you're giving a distal force? What's going to happen? The wire is going to start bowing like this, and that is the reason you have a vertical bow. So that's why sliding, that's one of the issues with sliding mechanics. Resistance to sliding, friction, notching, binding. We have to take care of all these factors.
Right. Can you brief on buccal self? I don't know what briefing they want.
I am in fact, I'm actually going into that. The next few slides are on the mechanotherapy of buccal itself.
Okay. With the introduction of skeletal anchorage, what's your take on how much percentage of skeletal class 3 occlusions getting converted to dental compensated treatment? So that is basically you are just changing the envelope of discrepancy, right? So,
yeah, I think the envelope of discrepancy has probably just advanced a little more with the advent of skeletal anchorage, but still the basics remains the same. The amount of bone still remains the same. You can't retract 10 millimeters on the lower or 5 or 6 millimeters on the lower because you just have that much of labiolingual cortex to do that. So you have to be very careful again. Usually class 3s are, there are some few things in which auto rotation of the mandible, etc., can be controlled. You can play around with a little bit, but you still have to keep monitoring it. I don't think the envelope has increased too much, but still cases have become more manageable.
Okay, great. Go ahead. I think we are done with the questions.
Okay. So now let me just touch upon some basic biomechanics when it comes to buccal shelf placement. Now, what I tend to use is I use a smooth mushroom head. The reason I use a mushroom head is because it causes less, what do you call this, inflammation on the gums. Stainless steel screws for extra-alveolar, because they're very stiff. The coefficient of its hardness is almost pretty similar to that of the bone itself. Double neck design over here to make it more smooth. Self-drilling edge for easy advancement into the bone. And what I prefer using is a 2 millimeter, a 10 millimeter or a 12 millimeter length screw, 1.8 or 2 millimeters in width is what I prefer using. Most of my cases have 10 millimeter screws that I've placed. Now, this one of my cases, you can see the position, you can see how much out of the bone it is. So you need a very long screw because there is no attached gingiva in this area. You're absolutely into the movable one. And it's very clear. You see, it's almost parallel to the long axis of the teeth. So that clears it from any kind of interradicular interferences while distalizing. And the point of application of force over the center of resistance. So these are the key things that you need to remember. Where you're going to use a power chain over here, which is going up to the hook, right? The CR is somewhere below it. So this is actually one of my patients, again, where I placed an IZC as well as the buccal shelf. The IZC almost always goes into the sinus. And The buccal shelf is steering clear of the roots, as you can see over here. One very important thing is you need to see is this. I mean, please try to understand that when you take off the 8s, we must not always assume that we have so much space, so we have about 10 millimeter space, so we can displace 10 millimeters. That's an absolute wrong notion. What I would suggest is, if you're ever planning a buccal shelf implant and a class 3 management, a CBCT is a must. There is no option there. It is a must. Now, why is it a must? It's because when you see a 2-dimensional image or an OPG, you feel that you have about good 7 to 8 millimeters of space over here. Once you get the 8 out and you can distalize, it's pretty clear. There's no other interference, right? But you cannot see the alveolar, the bone over there. And why I'm saying that is because you see this. From the coronal section, you can see that we have a lot of space to go back after the extraction of the 8. But when you go down, when you go to the apex, or when you see the apical section, you see that the distal lingual root of the second molar is contacting the mylohyoid ridge already, which makes it impossible for the second molar to go forward. Now this, how I learned is because I used to think the same. I started extracting third molars, placing buccal shelves and starting to retract. And it's been 4 months, 5 months, 6 months. And all I see is that the anteriors are tipping back and there is a posterior open bite forming. So this answers one of the questions as well from one of the participants as to why do I see bowing, right? This may be one of the reasons. Maybe that the distal lingual root of the second molar is already contacting the mylohyoid ridge and you're not able to gain any further distalization. All you're getting is vertical bowing and anterior tipping. So you have to be very careful to understand and see the distal lingual root and its clearance from the mylohyoid ridge before the start of distalization. And if you feel that it's already in touch, I think it would be a better option to extract the premolars. So I would say extraction of premolars in no way can be overruled, and this and third molars can be considered as a viable option all the time. No, it can't be. The limit of distalization, according to studies, by extracting the third molars and using buccal shelves has been pointed out to just about 3 millimeters. You can't distalize more than 3 millimeters, is what they say. So definitely you can retract much more by extracting a premolar. So please take into consideration these certain nuances when it third molars and using buccal shelves. So one more thing I would like to point out is, I am sorry I missed a slide here, but whenever you try to use a buccal shelf and to distalize, the action is, I'll tell you, you would find intrusion of the back teeth happening and extrusion of the front teeth happening. So it's more of a counterclockwise rotation of the occlusal plane which takes place when you try to retract using a buccal shelf. Intrusion because you're acting above the center of resistance over here, and extrusion which is beneficial in a class 3 open bite scenario. Is it clear, sir?
Yes, clear. Perfect.
All right, sir. So with that in mind, let's move on to another case, which was a more severe class 3. So as you can see over here, that this particular case came with a midline shift in the upper as well. You have a 3 or 4 millimeter midline shift in the upper. You have a fairly expanded upper arch, slightly protruded upper incisors, upright to retruded lower incisors, a huge class 3 canine over here, and a midline and a molar relation, probably because of the midline shift as well, and not so mild, not so severe over here, but the profile is bad. It's on a it's a protrusive profile. So the mechanics involved over here was let me just explain over here. My objectives of treatment were to correct the upper midline. Now, how do I correct the midline? I'm definitely not going to extract on this side, but I would use an open coil spring somewhere between this premolar and this canine in order to push the anteriors a little ahead, as well as to correct the midline. On the lower, definitely I would have to distalize, and I decided to not extract the premolars in this case and go in for extracting the third molar lying over here, because I had taken a CBCT and I found that the distal lingual roots of the second molars were pretty clear of the mylohyoid ridge. And so I thought that I had a good 4 to 5 millimeter space distal to the second molars. And so that was it. That was it. So retrude the lower, distalize the lower teeth, protrude the upper teeth, get the canines to a good class 1, get the molars to a good class 1. That was the objective, but it was easier said than done. So what happened is when I you can see the space over here in the third picture, which demonstrates that I used an open coil spring, which I don't have a picture of though, and I protruded the upper incisors, got the midline on. As you can see, the midlines are really off here and gradually getting on. And here I placed the buccal shelf screw on the lower. It's a 1925 night eye, still leveling the arches. And now it's a 1925 stainless steel. You can see the 2 hooks again, as I like it. And I've placed the 300 grams of force. I think over here, no, not here. I don't have a picture of it, but there was a time where I divided the force to 150, 150. Now what happened over here is, what hit me was that the lowers were not distalizing anymore, but where the lower anteriors were just tipping back. Now, when they started tipping back, I realized that I realized that because I could see the root prominence on the lower incisors, and it was just getting too prominent. One thing we must understand is nobody can correct a 5 or 7, 8 millimeter class 3 just by distalizing the lowers. Class 3s are always going to be corrected as a function of protruding the lower upper incisors, retruding the lower incisors, retracting the lower incisors, and at the same time, clockwise rotation of the mandible. So a clockwise rotation of the mandible is always beneficial for a class 3 because it gets your mandible in a slight downward and backward position. We can take advantage of this provided the case is not a high angle from the very beginning. Now, one thing over here is you can see that the position of the shelf I placed is not conventional. It's not a little high. It's somewhere almost at the level of the CR over here, the furcation, which did not give me the intrusion on the posteriors. In fact, it gave me a slight extrusive movement on the posteriors. Now, this is some technical stuff that you need to handle. And with experience, probably you're going to get that. You can see over here that the buccal shelf is placed way below than what it usually would have been placed somewhere here. Now, because it is low, the effect is not intrusion anymore. It's going to be extrusion. Now, extrusion is not good for the open bite though, but it is definitely good for the clockwise rotation of the mandible. And it's not that it's extruding too much. It's not intruding while distalizing. So eventually, the drawbridge effect also helped me to close this open bite. And eventually I was able to correct the open bite and the class 3 and the anterior cross bite, but the lower incisors were really retroclined. Now, here you can see the root prominence and the bulge. Now, there was this particular stage, I decided to take a CBCT all over again to see whether I am not outside the bone. Now, luckily, you can see here, in this slide, this was the day that I took a CBCT of the lower, and you can see that there is a very thin bone coverage still on the lowers. I decided not to play around more, take out the brackets on the lower. Unfortunately, I still had a scissor bite on the left side. So I decided to use the buccal shelf to correct the scissor bite itself and not use the lower dentition anymore. I placed in the fixed retainers on the lowers so that the lower anteriors didn't move much. And I wanted to start finishing the case as soon as possible. This was the stage where I took out the lower braces and started correcting the cross bites, placing the lingual button on the upper posteriors to 1/8 medium elastics to the lower buccal shelf to correct the cross bite on that particular side. The profile was corrected a lot, considerable amount. And this was when I debonded the case after 6 months post debonding the lower brackets. I got an ideal class 1 on both sides, and he was pretty happy about it, but I was not happy about the lower inclination. As you can see, I'm really retroclined. But unfortunately, it's a camouflage. Unfortunately, if you go trying to be a Superman correcting such huge class 3s, this is what you get. Now you just need to pray that the lower incisors don't go back because it's not stable. According to a paper by Hasegawa in the Angle in 2020, it says that if the teeth are not placed in the center of the bone, buccally and lingually, there is a chance of the 50% chance of dehiscence or gingival recession in the retention phase. 50% is too much, right? So I was very worried, and I had called him repeatedly for checkups because I was worried about his relapse condition and his bone levels. This was the amount of correction that I gained, but you can see the amount of correction over here with these. It's a tremendous amount of correction, and that's exactly why you have thinning. But what's the other alternative? You really don't have much of an alternative apart from surgery, which the patient was not willing for at any cost. You can either send the patient back, or you can give it a try and explain the nuances of relapse or detrimental happenings on the bone to the patient. And if he's still okay with it, I think you must give it a go. So you could see that the profile has greatly improved, and I was on a serious retainer checkup for him every 3 months. Fortunately, I have just I've seen him after a year, and there's not much of a relapse. Now I'm pretty confident that he's going to be pretty stable, because most of these relapses usually take place in the first 3 or 4 months, especially if you go in for such compromised treatment. Now, luckily, he's wearing his retainers, and as I mentioned before, I leave the buccal shelf implants over here with an Essex and a lingual button probably somewhere in this area near the canines. Give him nighttime wear. In this particular case, I did not give him nighttime wear because his lower incisors were already pretty retruded. I just left it in case I have to bond the brackets again. I would need the buccal shelf, and that's exactly why I left the buccal shelves over here in this particular case. This is where I got the biomechanics here. You see, this is what I was trying to explain. If the buccal shelf is placed at this level, which is at the molar bracket area, which is not the position that I've placed it here, it's way below the molar bracket, as you can see over here. But in the previous case, it was. In this case, if you place it at the ideal buccal shelf place, you see a counterclockwise rotation with extrusion of the incisors and intrusion of the molars taking place. Very good study. I urge people to read this study in the Dental Press Journal of Orthodontics by Marcio, and excellent paper for the biomechanics of class 3 and class 2 corrections, especially with the use of extraradicular screws. I have a short video of buccal shelf placement, which I would like all of you to see. You see, this is the buccal shelf, which I have placed. And usually I find the buccal shelf somewhere between the first and second molars. You might find it distal as well. It depends on the tooth. If you have a missing molar, you might find it more distal. In this case, please don't be surprised that I don't have a molar and still I'm using a buccal shelf. I don't have the first molar. I'm using the buccal shelf in order to distalize the second premolar to second premolar component in this case. You could use it for anything. In this case, I could have even placed the screw interradicular between the 7 and the 8, but I chose to place a buccal shelf implant. If you're using a 12 millimeter implant, you're going to find the head a little more out, and you're going to get the ideal counterclockwise rotation as you have seen. Dig a little deeper, go below the buccal tube, and then you're going to find the little extrusive component, not the intrusive component of the buccal tube, of the molars especially. Sorry. So is it clear, sir? Any questions?
Yes, clear. Questions, let me just read out. Any role in using Bollard's mini implant for class 3 cases?
Yes, of course, you can use a Bollard plate. I don't, because it involves surgical procedures. A mini screw would not require any surgical procedures, but definitely a Bollard plate is much better.
Can you enumerate complications associated with buccal shelf digitalization?
I'm sorry, I'm so sorry. Could you please repeat the question, sir?
Yeah, I think your pet is calling you.
My dog. Yeah.
Can you please list out the complications associated with the buccal shelf digitalization? Any
I have
complications, potentials?
the possibility of failure is very, very remote when it comes to a buccal shelf, because the bone is of very good quality. I have actually not faced much of any complications when it comes to buccal shelf placement. Even the gingival and the inflammatory response is pretty good, because quite a lot of the neck is sticking out of the gums.
Right. Okay.
It's a pretty safe procedure. It's a very safe procedure, safe thing to use.
Is there any option of or a method to avoid the intrusion of posteriors and extrusion of anteriors by distalizing the lower arch?
But that's a good thing. That's in fact a very good thing when using buccal shelf. Unlike in this case that I'm going to show you, open bite class 3s are good. You can use a 10 millimeter implant. That's what I said. You can use a 10 millimeter implant and absolutely go in. And what that will do is that will position you somewhere at the level of the center of resistance, or maybe below. In that case, you will find extrusion or no intrusion. But if your head lies above the center of resistance, you are going to find intrusion. So I think one way of doing that would be avoiding long implants.
Okay. Can the distolingual root of lower sevens be cleared of mylohyoid ridge using buccal shelf implant?
No, it's very, very hard to do that. That is a very big, long procedure to do, because you'll have to move the entire tooth out and then push it back, and you're functioning in very thick cortical bone. The chances of root resorption, and one of my studies, which I'm right now doing, is the effect of root resorption of the distal lingual root in buccal shelf patients while distalizing the entire lower arch.
Okay.
I think I'm going to be soon.
Okay. Question is, even if some space is created, why didn't you choose to protrude maxillary anterior dentition in this case at that particular stage?
This stage.
Yes.
Stage. Yeah, because the maxillary anteriors were already very proclined. I didn't have much of a margin to procline them further.
True. Okay. Hello, sir. Is there any inverse of bracket in lower anteriors?
I did.
Okay.
Yes. But the point was I used Damon brackets, and Damon brackets is -1. So they hardly made any difference.
And why didn't you go for lower premolar extraction?
Because I took a CBCT and I saw that I had good amount of space distal to the 7s. So I didn't find the need to extract the premolars. One more thing which reminded me, one question reminded me, is why couldn't I could have used high torque brackets on the lowers to avoid the retroclination. Unfortunately, in Cambodia, we don't have those prescription brackets. Variable prescriptions are not available. You have to buy a whole set for it. You can't mix and match brackets like probably you can do in India. If yes, I would definitely use what do you call high torque brackets on the uppers, as well as on the lowers in this particular case, because I was retracting them.
Okay. When does the extrusion lower anterior takes place with the use of buccal shelf implant?
When? Because if you place it ideally at the right position where your point of application of force is above the center of resistance of the molars, you're going to have intrusion of the molars and extrusion of the anterior segment. Now that might result in black triangles, and then you will have another headache.
Okay. In true class 3, does clockwise or counterclockwise is beneficial?
A clockwise rotation of the mandible is beneficial in a class 3, provided the case is already not a high angle. But in a class 2, CC rotation is much more beneficial. But we're talking about a class 3 open bite scenario where a CC rotation of the mandibular occlusal plane is beneficial.
Did you do any IPR in the lower anteriors?
No, I did not.
Okay. High torque brackets will be inverted or not in the lower anterior?
No,
I think he has already answered.
High torque brackets will be used as such because that would throw the crowns forward while I am retracting back and not let the crown tip like has happened in this case. But then again, even if I used high torque brackets, my logic over here is that the labiolingual cortex is just that thick.
Okay.
If I would have used high torque, I would have found fenestration on the lingual cortex, not on the labial cortex. So the story is still the same.
Okay, okay, okay. And if IZC and BSS comes in a non-sterile packing, should we autoclave prior to placement? Yes,
Of course.
of course, you have to.
You must.
In case of asymmetry, if you want to distalize on one side, would you place BSS on one side or both? One side only. Or
Yes,
you,
one side.
yeah.
I have had cases in which I've corrected the midline on one side by just placing the buccal shelf on one side and using one hook and getting the midline corrected.
Okay, I think we are done with the questions.
Great. Now let's go on to a scenario which is absolutely opposite. Now these are the tough ones. The tough ones are class 3s with a deep bite, and you have a curve of SPE issue, extruded lower incisors, very less of upper incisal display. The prognosis and the aesthetic component of such cases are very, very bad, even post-treatment. Now, I'll explain why. So, see, such cases are very hard to correct when it comes to flattening the curve of SPE. Again, I will be showing you two papers, which I'm very fond of. And before that, let me just put some perspective. You see, when you have a deep curve of SPE, what happens is when you put what we tend to do is we tend to place a night eye. When you place a night eye in the very beginning, the issue is that the curve of SPE will flatten eventually, but how will it flatten? What do you want? Do you want the back teeth to go up, or do you want the front teeth to go down? That's a very big question mark. So these papers basically answer those questions. A high angle case with a deep curve of SPE, you would not want the molars to extrude, right? You would want the anteriors to intrude. In such cases, it is always beneficial to never use a continuous arch on the lowers from the word go. In the beginning, you would always segmentally correct the back teeth as well as the front teeth and use an intrusion arch on the front in order to intrude the lowers. Because if you put a straight wire, before the lowers will intrude and posteriors come out, and that is the problem. High angle, the tendency is that if you use a straight wire, the posterior teeth extrude faster than the anterior teeth intrude, and becomes more detrimental to the case because it's already a high angle and becomes higher. So in such cases, it is beneficial to use an intrusion arch on the lowers. Similarly, on a low angle, the tendency is that you would want the lower posteriors to upright in such cases to flatten the curve. But unfortunately, that's not what happens because of the musculoskeletal pattern. What happens is that the front lower teeth protrude and intrude in order to flatten the curve of SPE. So it doesn't happen when you want it to happen, and it happens when you don't want it to happen. So that's the effect of the muscles in such conditions. Now, going to that, this was a low angle case. So what do I want? I basically want the back teeth to come up in this case, right? So what I did was I placed bite turbos on the anteriors, lower anteriors, and I started using elastics in order to flatten the curve of SPE from the very beginning. In this particular case, again, I extracted the third molars, and I want to distalize using buccal shelf implants. So you can see that I'm distalizing now after flattening the curve of SPE by extruding the posteriors or just uprighting the posteriors and maintaining the anteriors by using a bite turbo. And now I've started to distalize again and distalizing, and then finally I was able to get onto a good class one situation and correct the case absolutely to a class 1. Now what I'm basically trying to say in such cases is that such cases are so detrimental when it comes to the aesthetic point of view because they lose incisal display after treatment, because we tend to intrude the incisors so much that once the treatment is over, only the lower incisors are seen and the uppers are not seen. Example in such a case is this. You see, with such an underbite, you've treated them. Once you jump the bite, you hardly see the upper incisors. What I do in such cases is I use a curve of SPE on the wire. I tend to use a reverse curve of SPE wire on the upper, which will extrude the forefront teeth and create an open bite situation, which can be countered by the use of V elastics or any kind of elastics that you want to use in order to not let the bite open posteriorly. So what you're basically intending to do is extrude the upper incisors to gain some incisor visibility in such class 3 cases once you jump the bite, which is very important. So this is how I treated this particular case. It's paramount to understand how to flatten the curve of SPE in such cases. So again, I'm going to reiterate. High angle, usually if you place a straight wire, what happens is you will see that the back teeth are going up, which you don't want. So it's better not to involve the back teeth from the very beginning. Involve only the front teeth. Use a intrusion arch, intrude the incisors, and when it's almost flat, then engage a continuous wire. On the other hand, on a low angle case, what you want is uprighting the molars to flatten the curve of SPE, but unfortunately, that's not what happens. What happens is that the front teeth procline and intrude, and in order to avoid that, you need to control it by extruding the posteriors forcefully or orthodontically with the use of elastics from the very beginning. This is going to help flatten the curve of SPE in the right way. Questions, sir?
No questions.
All right. Yeah. So that brings me to a very, very hard case, one of the hardest cases that I've ever treated. And this is the beginning of this case. I don't have the records of it because the hard disk was lost, and whatever pictures I have on my phone is what I've used. So you can see that this case has gummies show a huge class 3. He has a very deep curve of SPE, and the worst part is he doesn't have good bone. He has knife edge bone, periodontally compromised, very, very poor oral hygiene, and thin knife ridge bone. When I received the case, he was something like this. You can see that I couldn't even know. I in fact thought that the pictures were inverted. So he was such a deep underbite, and you can see the curve of SPE. You can also see the knife edge bone over here. So my first agenda in such cases are basically to just tip the lower incisors back. Now I started tipping it back by the use of some segments and a T-loop over here. I reinforced the anchorage using mini screws, which are interradicular. And I used the T-loop with some segments to just tip the lower incisors back. In this case, I raised the bite at the backside of the premolar region and tried to jump the bite as soon as possible. Towards the end, I started going in for a coil spring, and I somehow was able to get an edge-to-edge relationship. Now, once that happened is when I decided to start using a continuous arch wire. You can see the poor oral hygiene, and you can see that such cases are very, very hard to treat. I started using a 1622 stainless steel with the extra long loops to increase the flexibility, close those minor small spaces, and try to get the lower teeth into the arch. I had many issues in this case, even with the cross bites on the sides. Now I decided to correct the cross bites using elastics from the lower closing loops to the palatal surfaces of the upper molars. As you can see over here, yeah, you can see this here, that I've been doing that particular thing. So yeah, here, the idea was basically to jump the bite in the beginning and to tip it, because fortunately I had protruded lower incisors because of the iatrogenic effects of the previous treatment. And finally I was able to jump the bite. And once I jumped the bite, the forces, as you can see over here, are absolutely minimal. It's less than 50 grams of force that I'm using to close this space. And the key to closing spaces are very light forces. I did not believe that I was probably going to close the space, because you wouldn't believe that the ridges were that thin. But fortunately, with the light forces, I was able to remodel the bone, gain bone thickness, and I was able to close these spaces absolutely and completely. And towards the end, I was able to get the midlines on, good class ones. And now he was in a very big hurry because he had already undergone treatment for about 4 to 4.5 years, and he was in a hurry to get married. So he requested, and he was really urging to get the braces off, and we had to get the braces off. I couldn't correct the torque properly. I would have wanted to correct the torque properly, but given this finish, I would pack back for getting such a finish out of this particular case from the very beginning. This was one of the hardest cases that I've treated, considering the sheer fact that the periodontal condition of the teeth, the bone, oral hygiene, and the knife edge bone were pretty detrimental to the entire treatment by itself. One more thing, by the way, is this patient, every time he came in with at least 3 or 4 pop-outs, which made it very difficult for me to progress from a wire to a higher wire itself, because you know that once a bracket pops out, the teeth is never in that same position again, and then I have to wait for it to align all over again. So that's why this took a little more time, but in the end, I was happy, and he was elated with the result. So now that brings me to the last case of my presentation today. So do we have any questions?
Yes, we do have. Are there any cases where you prefer to include second molars in your treatment?
Almost all the cases.
Okay. How to counteract the side effect of buccal self-implant, which is the intrusion of anterior and extrusion of posterior, especially if the patient is already low angle case. So it is beneficial, no, if it is low angle.
See, if it is a low angle, I would prefer placing a shorter implant for the 10 millimeter length, so that you go a little lower than the center of resistance, and that would extrude the posteriors a little bit.
Yeah, but it will be beneficial because you are actually increasing the anterior facial height, lower facial height.
Yes.
Right. Okay, let's go ahead.
Okay. So now that brings me to the last case. Again, a severe class 3, a surgical class 3. She came in and she was like, basically she had a psychological issue. Her parents had spoken to me separately, saying that she's having psychological issues because of her dentition and her face. And unfortunately, I think there was some marriage issues particular case. Now, either ways, I diagnosed it as a very, very clear surgical class 3. But still, the patient was nowhere close to get surgery done. And moreover, the complications with this case is something here that you can see. You can see that there's 50% bone loss on all her teeth. There is a grade 1 to 2 mobility on all her teeth, on the lowers, especially on her lower anteriors. Very high angle, which is detrimental to a class 3 by itself, because you can't clockwise rotate the mandible any further, which would increase her facial height and would not look aesthetic at all. Also, you can see a very deep curve of spee on the upper, and you can see open. So whatever you want to ask for, you get it in this particular case. Now, how do you, again, just to reiterate the issues: missing molars, grade 2 mobility, severe open bite, less than 50% bone, high angle mandible, and broke. She didn't pay me a penny for it. So what I decided to do in this particular case is something which I think many of you would not perform. I decided to use a light night eye wire on the upper and started to intrude the upper posteriors with a very light night eye, with an 016 night eye itself. Now, the rationale behind doing this particular thing was, I do understand that you're going to have buccal flaring of the posteriors when you use it on a round light gauge flexible wire. But it was beneficial in this case, because you see this patient had a crossbite, and the cuspal positions were such that there was a premature contact with the buccal cusps of the uppers. So when the buccal cusps actually move out of the way, the open bite would actually reduce. And as you can see in the subsequent pictures, you can see that intrusion on a light night eye itself has been closing the bite as well as correcting the cross bite. As and when I went to a stiffer wire, I was able to correct the crossbite, but you can see a heavy midline shift, right? You can see a very, very good amount of midline shift. Now that is something that one of the previous participants had asked. I placed the buccal shelf implant and I have distalized only one side. And as you can see, the midline is gradually correcting. Now over here, I have also used some horizontally fashioned class 3 elastics in order to close the space and get the lower teeth within the upper teeth. At the same time, I'm continuing the upper intrusion because I don't want to lose the effect of the intrusion with the use of such horizontal class 3 elastics, which may tend to extrude the posteriors. Now, one thing which you would see is I have used 2 wires on the lowers for leveling alignment. The rationale behind using it is again something to do with tweak. What I do is I try to make, as I mentioned, that there was mobility on almost all her teeth. I had to use very, very, very light forces. Now, one way of reducing the forces is increase the interbracket. What I've done is I have used wires and I have the brackets on the terms of attachment. That means one wire is being attached to this, and this. The second is from here, here, and here. So what I'm doing is basically I'm increasing the interbracket distance while leveling and aligning so that the amount of force which is applied on each tooth to derotate or to align it is very, very minimal. Am I still audible, sir?
Yes, you are audible. Absolutely.
Okay. And towards the latter stages of this particular case, as when the line had begun to correct after distalization and when the space had closed, I decided to use midline elastics from the upper lateral to the lateral. I just tend to place some Kobayashi hooks and go in for 1x4 medium elastics to do something of this sort. And I was able to correct the entire malocclusion. Now, in the beginning, I had told her definitely that I might be able to correct your dentition, but your chin is still going to stay prominent. You might need a genial shaving at least, if not anything else. She had agreed to it because I was able to manage it for a very decent price. But in the end, I was surprised that her soft tissue and her hard tissue had somehow uh, uh, fallen into a good paradigm, which need not have needed any more genial shaving. So as you can see, I was able to get a good class one and all these things, but you can see some amount of soft tissue clefting. Paramount reason would be because there is no bone, first of all, and any amount of force would just cleft the soft tissue before remodeling, which would cause a soft tissue cleft, which I presumed to increase towards the retention phase. And as you can see, I have been successful in not increasing the mandibular plane much. Retraction of the lower incisors has been considerable. Upper extrusion as well as retrusion has taken place in this particular case. As one more thing is that the periodontal condition has not gone detrimental. It has almost stayed to the very same level as it was. By the way, this patient had undergone a deep scaling at least 3 times before the onset of braces. And parallelism was okay, and I was able to maintain the same amount of bone height. Now, the good thing is after about 1 year, you can see that her soft tissue and her teeth are still in an okay position and not relapsed, which I was anticipating though, considering her periodontal condition, but luckily nothing happened. And again, as anticipated, the soft tissue cleft over here is pretty prominent. So this was the before and this is the after of the treatment without any kind of genioplasty or without any genial shaving, which is just dentoalveolar nature. And luckily, the soft tissue and the body has a good way of helping you out at times. This paper can be accessed, and the title is The Periodontally Compromised Severe Skeletal Class Bite Corrected by Orthodontic Camouflage Using Temporary Anchorage Devices. It's published in an open access journal, APOS Trends, and I would urge people to have a look at this if they're interested in the biomechanics involved. In the end, I would like to thank everybody for staying for so long with concentration. I know it demands a lot of concentration. And I would like to end by saying that a man who doesn't spend time with his family can never be a real man. And that's by Don Corleone from The Godfather. And this is the right time for that, isn't it? It's stay home for Corona and stay with the family. So thank you. Thank you so much.
It's a pleasure for us. Okay, can we take few questions?
Of course.
Okay. Question is, what precautions need to be taken while unilateral distalization with the buccal self, as there is non-fact of occlusal plane canting?
Yes. See, there is a good chance of your occlusal cant happening, but since the forces are very parallel, if you place the buccal shelf at the right dimension, right, it is still almost at the level of the buccal tube. You won't see much of that happening. But even if you see that happening, there are many other ways of correcting it. You can just alter the bracket positioning a little bit because it's going to be minuscule.
Right. Okay. In the last case, have you avoided the gummy smile?
In the last case of the girl, I did not avoid the gummy smile. You can see that the gummy smile is still pertinent.
Okay.
Because the anteriors have extruded.
Okay. Sir, in many of your cases, you have used loops to close the space instead of each end. What is the reason for same? Yeah, it's okay.
I'm a tweak guy. So I love using loops. There is no difference basically in arch wide guided traction or loops, but I just prefer using loops because frictionless mechanics, as I mentioned before, nullifies the factors of resistance to sliding,
You are
binding,
under
notching.
control. You are under your own self.
And I don't have the problems of binding and notching and resistance to sliding with loops. So it's very controllable.
Okay. Sir, risk and complications are associated with this type of treatment. What's your take on this, especially for novice practitioners?
I wouldn't recommend jumping into such treatment modalities in the very beginning. But I mean, who can stop you from trying? You would learn. I have learned everything from just trying, making mistakes. Go ahead, clear out everything with the patients, give them all your options, and then you can try. Within the realms of the biological limits, you can try almost everything.
Perfect. Okay. There's a question. Why don't you consider flipping the bracket of lower incisor to help control the torque while retracting the lower anteriors? I think because he said he's using low torque bracket. Right?
I did. No, I do that in certain cases if I'm using MBT to get the -6 to +6. Some cases in Damon are useless because this is -1 to +1 of a difference, unless I'm using low torque brackets. Low torque brackets, as I mentioned, are not available here. That's why I tend to usually torque the wire than use the torque on the brackets. So I torque the wire itself. But again, if you're retracting considerable amounts in terms of 5 mm on the lowers, it is not effective because the labiolingual cortex is just that thin. If you try to even push the brackets forward and use a high torque and then retract, you're going to expose the lingual. In this case, you're tipping the bracket and you're going to expose the labial. So eventually, the envelope of you retracting is still the same. You don't have that amount of freeway that you have in the maxilla, that you have in the mandible. You don't.
Okay. Sir, in buccal self implant for intrusion of molars, it's below the center of resistance of molar, right?
No, usually the head is above the center resistance of the molars. And that is why you get an intrusive force.
Perfect.
But if you really dig in deep and use a smaller implant, a 10 mm, it goes inside more, you will see that it is almost at the level of the CR, and then you're not going to get intrusion.
Perfect. Okay. Can I share a screen for some time?
Absolutely, sir, please.
Right. Yeah, I'll just share my upcoming webinars details.
You're doing a wonderful job, sir.
Thank you.
Arranging so many people. It's very hard.
It's hard, but I'm somehow, I want to give best to everybody because, as you said, caring for your family is the best thing you can do. And like, I feel that all orthodontists are part of our family. We are all extended family.
True.
Then we have tomorrow is Dr. Giorgio Iodice, and he's one of the best when it comes to guided palatal TEDs. And I'm sure Dr. Adith knows him as well.
Yes, I do.
So don't miss his tomorrow 12 o'clock. There are two more to go, and then this is Dr. Jay Bowman's on 28th, evening 5:30 Indian time, 8 o'clock New York time. And he'll be speaking on improving the predictability of your clear aligner system using the adjuncts. So, in fact, you can say that he's increasing the envelope discrepancy by using aligners along with the adjuncts for treating complex cases with the aligners. So don't miss it for anything. It would be a treat, something like what you had a treat with Dr. Adith Venugopal today.
Thank you, sir. I'm really glad all of you liked it. I'm seeing the comments right now. For the first time, I'm actually seeing the comments on a Zoom webinar. It's
And this is a webinar
pretty
platform,
good.
which is far better than that meeting platform,
Oh, absolutely.
Yeah. Okay. Now then we have somebody called Dr. Aladdin Sabag.
Wow. Yeah,
Sabag is
I
an
know him.
amazing guy from Germany, and he would be speaking on non-compliance. That includes everything. He is an inventor of one of the appliance also for mandibular
SAR.
SAR, yes.
Yeah.
And he'll be speaking on aligners also, and he'll be speaking on TADs also. So it will be all everything for non-compliance. He will be speaking on Sunday, the fascination and limits of the non-compliance orthodontics.
I believe Dr. Sunanda Roy Chaudhary was also speaking on class 3s today.
Today, yeah.
Mm.
She spoke on the other platform. Meanwhile, you started having questions also, but I think they'll give your email address because otherwise your family would be needing you as well.
So we've answered all the questions, isn't it, sir?
Yeah, we did almost.
Okay.
Yeah, there are 22 for you. There are so many good reviews on the chat. I think you must have read it.
I'm just going through them.
Okay. Thank you all for joining, and thank you, Dr. Adith. Multiple times you came on our platform. In fact, you even
Thank
came
you, sir.
to Ahmedabad and gave us a chance of having a
No, that was my pleasure. That was absolutely my pleasure. By the way, I always say this to everybody. These AirPods are all thanks to Dr.
You
Ajay.
don't have to, you don't have to say that. Right? It was our pleasure. And thank you all attendees for making this program successful, because without you guys, even the speaker would not be encouraged to speak. So from all of you are coming from all part of the world at different timings. I would say that from every continent of the world. Thank you all for joining in. See you tomorrow at 12 o'clock Indian time. Please do register as soon as possible because we have limited numbers and all these international speakers, the slot will get filled as soon as possible. Thank you, Dr. Adith. My regards
sir.
to you and your family. Stay safe. Bye, all of you. Good night.
Sir, photos, okay? I need to fill Facebook now.
Sure, I'll share.
Thank you so much, sir. Thank you so much. Have a nice day. Have a nice day to everybody.